of course. So I'd like to wish everyone good morning. Jan, how's that telescopic vision coming along? Okay, you know, if it's still in a beta phase, you could move up to the front. I'm told there's still some seats up here. Come on, guys, move up, please. Come on. Okay, well, first housekeeping. The usual surveys, completion of the surveys is supposed to be important to maintain CME accreditation and to continue to deliver appropriate content. That means please fill them out. We are videotaping, live streaming, and we're on Facebook. So as I've been warned, watch what you say. There are certain words you cannot use. Ziad, that goes for you too. We listen to your feedback and now offer ABIM MOC credits. Anyone who's planning to recertify, remember the clock's ticking. You got to meet your 100 credits by the end of the year to recertify. Last but not least, don't forget about pumps and pipes Monday morning. Be there. Okay, so enough of that. It's my absolute pleasure to introduce a friend and colleague, Dr. Ziad Ali from Columbia University. His CV is so long, I thought I'd remember all the details, and there are too many accolades, too many grants, too many publications, too many achievements to fit in a small brain like mine. But Dr. Ali is Associate Director of Translational Research. Dr. Ali's major contributions include steps forward in intracoronary imaging, where he's been a pioneer, intracoronary physiology, and development of new interventional techniques, such as intracoronary lithotripsy, which I hope he's at least going to mention this morning. If not, we'll ask you questions about it.
Sure.
So, Ziad, it's an absolute honor to have you here. I think we universally enjoyed sitting down to dinner last night. We very much look forward to grand rounds and look forward to chatting with you afterwards. So come on up and tell us about conserving or avoiding contrast during PCI, keeping the nephrologists happy, and really fulfilling an interventionalist's dream.
So thank you so much for inviting me to this Grand Rounds. I think the most excited person about Grand Rounds is actually my wife, who was born at Methodist and is a die-hard Houstonian. She's probably watching online, so good morning. So I'm going to talk to you this morning about reversing this concept of renalism in revascularization. And going through some of the steps that I learned while I was at Stanford in biodesign about how to implement areas of expertise and develop new technologies and new techniques. These are my disclosures. So I thought I'd start with this because I thought it was kind of fun. So anytime that you need to introduce yourself, probably the most succinct way is to look at my newly found Twitter account. So I'm an interventional cardiologist and a vascular biologist. I actually worked with John Cook when I was at Stanford. I'm a clinical trialist at CRF, but most importantly, I'm a son, brother, husband, and dad everywhere else. So while I was putting this slide up, my wife actually saw me making it, and her first point as she looked at it was, why do you never have any battery? So I'm going to move forward and talk to you about the landscape that we're now in for PCI in 2018. So we all remember this study, which in fact was a paradigm shift. The COURAGE study randomized patients to medical therapy versus PCI and medical therapy and found no significant difference at long-term follow-up in terms of risks for death or myocardial infarction. And this had actually profound implications on our field. What you can see is the temporal trends in the use of revascularization since the implementation or the publication of COURAGE is that there's a significant decrease in revascularization in both elective CABG and elective PCI, as well as PCI for both and CABG for myocardial infarction. Now, some of this is highly likely to be appropriate, But some of this is highly likely to be inappropriate. And what you can see is that when you take patients who have non-ST elevation myocardial infarction and left main and even 3 vessel disease, which has a prognostic benefit from revascularization, the number of patients who are undergoing medical therapy is increasing dramatically without revascularization. So what does this mean for the interventionalist? What this means for the interventionalist is that we are now seeing patients much later. So we can't really easily perform single vessel disease PCI without optimal medical therapy. We need to give them a trial of anti-anginals. We've all seen the results from Orbita. And so what is happening is that we're now seeing patients at a much later stage of disease. And as you all very well know, atherosclerosis is an ongoing and progressive chronic condition. And while medical therapy may delay, it cannot halt atherosclerosis. And I think this is a good example of that. So this is a patient of mine who I've seen pretty much as long as I've been at Columbia. And you can see she's 57, she develops diabetes, and in 11 years' time, she has developed horrendous, severely diffuse coronary artery disease. So medical therapy is excellent, but in certain situations where we can treat things up front, it might be advantageous. So this brings us up to this new concept, which has kind of been, I shouldn't say pioneered, but certainly pushed from our institution at Columbia and Cardiovascular Research Foundation, and that is this concept of a complex, higher risk indicated patient. And this really takes into account the patient's anatomic considerations, their comorbidities, and their ventricular function. And so this is what it comes down to. So these are 2 separate patients. They're both 55, they both have hypertension and hyperlipidemia, and they both have 4 months of exertional angina, and they both have exactly the same stress test. And it happens to be that they're twins. Now, the patient number 2 undergoes a simple, straightforward revascularization on the spot, and patient 1 undergoes medical therapy and does not undergo revascularization until they come to us for CTO PCI many, many months and years later with ongoing symptoms and some loss of ventricular function. So why do we treat these patients so differently? So I think we've talked a lot about this concept of CHIP, or complex and high risk patients, but what we really haven't done is define who these patients are. And so I think we're getting better at that. I like to call this the clinician's definition of CHIP, and you can see we've really divided into people who have hemodynamic abnormalities with low EF and high end diastolic pressures, complex patients, which include diabetes, chronic kidney disease, and end-stage renal disease, and non-ST elevation myocardial infarction, and then a host of anatomical considerations where we know that the target vessel failure is fairly crude, but I think elegant in the same way. And that is that we took all of the patients that we had individual patient data for from all of the randomized controlled trials that were conducted through CRF, and we looked and said which patients don't do well after PCI. And you can see that it's diabetic patients, non-ST elevation MI patients, and then patients who have bifurcation, moderate to severe calcification, chronic total occlusions, and previous stent failure. But the highest hazard ratio of all of the patient subpopulations is if you've got CKD or end-stage renal disease. You do not do well with stents, with a progression towards death, MI, need for renal replacement therapy, or heart failure. So I won't belabor on this. You're all very familiar with its classic definition we all learned in medical school about the stages of chronic kidney disease. And I'm really going to focus on this area where we really need to pay a focused attention. So my talk today is about some of the negative effects that radiocontrast can have in this specific patient population. I think if you have a patient with a GFR of 60 or 90, the amount of contrast that we deliver really makes very little impact on the patient's outcome. But in patients who have advanced chronic kidney disease, that's clearly not the case. And you can see there's a host of effects of contrast media, which include biological events, molecular events, but all ultimately leading to toxic injury to the kidney, leading to acute renal failure. This is a definition for contrast-induced nephropathy. There's been a bunch of them that have been described, including new markers. But for the most part, it's an increase in the serum creatinine by 25% or an absolute increase by 0.5 milligrams per deciliter. And one of the things that is unique about contrast nephropathy is that many times we don't really look for it. So what we do a lot now, of course, is same-day discharge after PCI. And so the peak of this contrast nephropathy actually happens between 24 to 96 hours. And there's a lot of risk factors, many of which are fixed, which you can see on the right side of the screen, but there are many things that we can take care of as interventionalists very early on, which includes volume, the patient's hydration status, their anemia, and what drugs they're getting in order to prevent this. So I'm kind of harping on about this, but why? What's the point? Does it really matter? Well, this is some of the evidence to suggest what happens if you develop contrast nephropathy. You can see it significantly increase hospital stay, intensive care unit stays, and the need for hemodialysis, which of course is tremendously life-altering. You can also see there's a major cost implication. There's for each half a milligram per deciliter elevation in creatinine, there's a significant increase in cost. As my friend Shoab Tamber, who we did residency with, will be able to tell you, these patients on CKD provide also difficulty for medical therapy because many physicians are unwilling or have difficulty with prescribing drugs which are known to be nephrotoxic or potentially nephrotoxic, such as diuretics or ACE inhibitors. But even in fact, you can see there's a significant reduction in the use of beta blockers. Ultimately, what does this add up to? Well, what it adds up to is you can see that if you got chronic kidney disease to begin with and you develop contrast-induced nephropathy, you have a pretty appalling chance of death at 1 year. So that's a 25% mortality. There's not many things in medicine, maybe aortic stenosis, that we leave alone that's not treated, in cardiology at least, where there's such a profound impact from a single possibly preventable event. You'll also see that even those patients with no CKD who have contrast nephropathy have poor outcomes. And so as a result, revascularization by PCI in patients with advanced CKD is drastically underutilized. So it turns out that cardiovascular disease accounts for 53% of all-cause deaths in patients who have CKD. It remains the leading cause of death after renal transplantation. And one of the biggest problems is most of the randomized controlled trials completely exclude this from their trial setting. The reason is in contemporary practice, most trials are made for approval of devices, so they want the simplest and easiest population, and they're not necessarily designed to ask clinically relevant or practice-changing programs. So I mentioned in my title this concept of renalism. So what is renalism? Well, this is it. So you can see in these 4 large studies, if you have any stage of chronic kidney disease, you are significantly less likely to undergo angiography than you are if you don't have CKD. So this is this concept of renalism. And so here's a further example. So I showed you an example where there was a difference of 11 years. But here you can actually, I'm going to go back one slide here. You can see the progression of atherosclerosis in this patient in little over 9 months with medical therapy. So this patient population is extreme risk, not just high risk. And the benefits of PCI in this patient population are very, very clear. You can see that revascularization from the available data in almost 16,000 patients shows a significant benefit for revascularization in this patient population as compared to, say, for example, the COURAGE population. You'll notice that an eGFR of less than 30, it's not a significant difference. And the reason is there's no data. It's very hard to get tight confidence intervals if you have 7 patients per group. So we're really not good at keeping information in this area. So what simple things can we do? Of course, you can see there's a direct and linear relationship between contrast nephropathy and the amount of contrast that we use. The simple strategy here would be to limit the contrast as much as possible and to focus on modifying the risk factors for contrast nephropathy. This is probably the most widely used risk score, the Moran classification, which can help you understand what the likelihood of you developing contrast nephropathy. It's basically developed from odds ratios of a registry series, and you can see that patients who are in shock older patients, anemic patients, and diabetic patients tend to do worse. And of course, with the appropriate use criteria and with the limitations that we have now for performing PCI early, this is the type of patient population we're seeing. So let's move on. What are the treatment strategies? I think this study deserves a lot of attention. It's probably the most contemporary study. It's a very large randomized controlled trial called PRESERVE. It randomized almost 5,000 patients, and it categorically proved, I believe, that in patients with CKD stage 3 or 4, that there's no benefit of sodium bicarbonate over sodium chloride, and there's no benefit of N-acetylcysteine over placebo. So this builds on previous data, the ACT study, which showed the same thing. So as of right now, the only therapy that works is some form of hydration. It doesn't matter whether it's sodium bicarbonate. It doesn't matter what type of contrast agent you use, hyperosmolar versus isoosmolar. You see in this 414 patient study, there are some trends, but not even close to statistically significant. And you can also see that there's no difference in this large contrast study. So we don't have changing the contrast right now. What about experimental strategies? Well, there's some kind of cool technologies, I think, that are coming out. This is a technology where the injector will not allow you to get any backflow into the aorta. So as soon as the pressure increases in the catheter, it will not allow reflux into the aorta, and it can decrease your contrast by a small volume. There's another new system that's in randomized controlled trials called Renal Guard, which is fairly interesting, and basically what it does is whatever fluid you put in, it matches taking it out by using diuretics. So it's basically 1-for-1 weight. And there's some early data to suggest some benefit, but the large randomized controlled trial has just finished. So what about clinically validated strategies? What works? So what can you guys do in the cath lab or before you get to the cath lab? There's only really two things. One is adequate hydration. This is the Poseidon study published by Somjit Brar in The Lancet, which shows that if you use a left ventricular end diastolic pressure guided hydration strategy compared to a control strategy, you can significantly improve outcomes in patients with chronic kidney disease. The only other small study, which is of 70 patients, showed that if you use intravascular ultrasound to guide your procedure, instead of using contrast in these patients, you can reduce the amount of contrast used by about 50 milliliters. So I mentioned to you before, I was part of the Stanford Biodesign program, which is an amazing development. It's basically the engineers and the doctors put together in exactly the same place, and it's all centralized around the cafeteria. So they've made a great cafeteria in between the hospital and the engineering school. Everybody gets together, and that started off this program called BioX. So the point of this is really that it focused, for those people who are involved in it, it focuses on identifying needs. And of course, in chronic kidney disease, there's limited treatment options, as I just showed you. And we know there's some concept generation, so the concept for us was, well, what if we use ultra low levels of contrast and we make a roadmap? Can we actually do this without using dye, using other technologies? And then finally, what are the alternatives to performing angiography in this case, which includes intravascular imaging and physiology? So we have to step back when we're trying to invent some new technique or new technology and think about what the needs are and what the alternatives are. And we'll talk a little bit about intravascular lithotripsy at the end. So of course the goal of PCI is first to not do any harm, right? So we don't want to create a periprocedural MI, and we don't want to lose side branches, and we want to relieve ischemia, and we can make sure we don't have complications by using intravascular imaging. We can relieve ischemia by performing FFR or IFR, measuring pressure as a surrogate for flow, and we can improve the prognosis if the coronary flow goes up, right? So we have all these tools to know whether we did a good job. So this is how I put my expertise together. So I'm the director of the angiographic core lab at CRF, so I know how to toy around with angiograms. I'm the director of intravascular imaging and physiology at Columbia, and I'm a vascular biologist. So I put all these things together and said, how can we make it so that we can get around these problems? So let's talk about the limitations of angiography. So by angiogram, we don't know what the plaque distribution and extent is. We see here a lesion in the proximal left anterior descending. We don't know what this is made of, whether it's calcium. It's not predictable to us. We don't know what the percent stenosis is. We often use our visual estimation, which is quite poor. We don't exactly know how big this artery is. We guess based on our experience of doing many hundreds or thousands of procedures and say, it looks like it's about 3 millimeters, but it's hardly precision. And then finally, for PCI complications, we're looking at the angiogram as the answer, the be all and end all, and say if there's any problem. It's interesting, interventional cardiology is one of a few specialties where at the end of the procedure, we can just look at it visually and say, yep, looks fine, we're done. So, cancer surgeons can't get away with that. We need some objective evidence to show that you've done a good job, histology, etc. So we can identify the plaque composition using ultrasound, right? So this is intravascular ultrasound, which shows us that this intracoronary lesion is fibrous. One is fibrofatty. This is heavily calcific, and this has a large degree of lipid in it. And this requires a small amount of training, but it's easily performed and regularly used in the cath lab on a day-to-day basis. And as Neal mentioned, I have a very avid interest in optical coherence tomography, for which we are running the largest international randomized controlled trial comparing imaging to angiography guidance in about 3,500 patients called Illumian 4, and we've now randomized 300 patients in that study. So we're very excited about that to show if it improves outcomes. But nonetheless, we can very easily see what we're dealing with high resolution. This is the resolution of a histologist slide, and look at the inside of the coronary. And we can also see if there's complications. So using ultrasound, we can see if we've torn the artery, if there's tissue sticking out from our stent going up at high pressure, if the stent has come off the wall. And we can do the same thing using optical coherence tomography and see this at actually very, very high resolution. And what else do we know? So Illumian 3 was one of the first randomized controlled trials, in fact, the first randomized controlled trial, which compared OCT versus IVUS for angiography. And what we showed is that if you use intravascular imaging compared to angiography alone, first of all, your stent is bigger. And so ultimately, the goal of stenting is to put in the biggest highway possible so you don't get a traffic jam. So minimal stent area is the most important predictor of long-term outcome. And also that we leave the least number of untreated complications using OCT, which has the highest resolution, and then IVUS, and most of the stuff we leave behind with angio because we can't see it. And we also know that from large meta-analyses that intravascular imaging categorically and irrefutably changes the patient's outcome. So this is a meta-analysis of 30,000 patients, which shows that basically every outcome you look at, there's a reduction in death, MACE, stent thrombosis, target vessel revascularization, et cetera, et cetera. So there's very clear evidence of benefit, and now there's 2 large-scale randomized controlled trials which have been recently published, which also show a significant reduction of about 50% in your target vessel failure at 1 year. So we know we can get through the complications by imaging. We also know that if we measure the pressure in the artery as a surrogate for flow using FFR or IFR, we can reduce outcomes and reduce MACE. So this is data from the FAME study, which showed that if you use an FFR-guided approach as opposed to an angiographic-guided approach, we can reduce the rates of death and myocardial infarction. And then finally, we can also measure the coronary flow reserve. Although we don't do this very often in the cath lab, we certainly have the technology that's able to do it. And we know that perhaps the single most important predictor, even above minimal stent area, is that if you actually increase the flow in patients with revascularization or otherwise, that patients live longer. So put simply, if you have normal coronary flow, you live a long time, and if you don't have normal coronary flow, you don't live that long. So as a result, why do we need contrast? Well, the reason is because we need a roadmap, right? So we need to know where we're going with the tools and gear. So we started this study, which was to determine the feasibility and safety of using ultra-low contrast angiography. So this was a single center study where we took patients with CKD stages 4 or 5 and an eGFR of less than 30. We enrolled 104 patients, and we randomized patients to ultra-low contrast versus conventional angiography and looked at the need for renal replacement therapy. And so what's ultra-low contrast? So ultra-low contrast we defined according to this previously published work, which showed that you increase the risk-adjusted and crude rates of contrast nephropathy once you get to a contrast volume to eGFR ratio greater than 1. So when you're below 1, You're extremely safe, and when you go above 1, you start to get on this algorithmic or logarithmic part of the curve. So what that means is we have to use a contrast volume to EGFR ratio of less than 1. We have to dilute the contrast in situations where the GFR is very low. And then we just have to take very limited views. So 1 picture in the right coronary and 2 pictures in the left coronary. And that hydration has to be guided by the left ventricular end diastolic pressure. And this is an example of an ultra-low contrast angiogram. There's 3 views. This angiogram is done with less than 10 milliliters of contrast. It answers all of the questions that we need to know. It answers even whether there's an ambiguous lesion or not. And so this is an example from the trial of a patient who was randomized to standard of care with severe chronic kidney disease. As you can see, a GFR of 16. And you can see that using ultra-low contrast, you can get the same information with very little dye. Now, there's some situations where there's such an ambiguous lesion because you can't take multiple views that it leaves a problem to you, right? So you didn't really see it. You need another view. Well, we have the technologies to now know whether or not that's a problem. So we have a pressure wire. So if we put the pressure wire down past the ambiguous lesion, it can actually tell us what the flow is like or what the surrogate flow is like. So we don't need to use multiple images where the risk of injury to the kidney is high. So this is the data. This is our 105 patients. You can see a fairly standardized group between standard and ultra-low contrast. And these are the outcomes. So in the ultra-low contrast group, we were able to do this with about 13 milliliters, standard 43 milliliters, and you'll notice that there's a significant improvement in the outcomes in terms of contrast-induced nephropathy, preservation of renal function, and most importantly, the need for renal replacement therapy at follow-up. So on the left side, this is a spline curve, and what the spline curve tells you, and I think this is important, is that there is no low-risk zone. So even if you give 5 mils, you can create an injury. So the lower, the better. But you can see that the hazard ratio is around 1 when we get to a CV to EGFR ratio of 1, which is why we think that this is actually entirely appropriate. But look at these clinical outcomes. So these are profound changes by a very simple approach in the cath lab of just minimizing the amount of dye that you can use. And if we looked at the univariate and multivariate predictors and we entered all the things in the model where we normally are concerned about kidney injury, everything drops out of the model except ultra-low contrast angiography. So performing this very simple step in the cath lab using conventional technology and catheters, we can improve outcomes. So you can also do this in bypass surgery, so it requires a little ingenuity. So here's an example of where we don't take any pictures marking the groin. We use ultrasound to mark where we're going to get access. And then you can see there's a single apicaudal view. And then how do we find the grafts? Well, we find the grafts by heparinization and using guide wires, right? Guide wires are extremely safe in today's day and age. And by heparinization, we can identify exactly where the graft is and then take a picture. So we never, ever take a puff that isn't going directly into the coronary artery. This is identification of the saphenous vein graft. You can see here, we're trying to identify a graft by using the wire, and then the catheter here seems like it's popped in, and now the guide wire enters into the vein graft and is moving very freely, and as a result, we can take a picture and answer all of the questions without wasting any dye. I'm going to show you this very unique technology which we were involved in the development of, which is called the dynamic roadmap. The dynamic roadmap actually takes your previous angiogram and maps it directly onto the screen so that you have a working roadmap in the cath lab. So this has really simplified where we started a few years ago to the point at which this can be activated and used in every case rather than in selective cases. So that brings us on to zero contrast PCI. So now that we have a roadmap, we can actually perform PCI in these patients without giving any dye at all. And this is our first experience that was published in late or early 2017 in European Heart Journal, where we published our first 31 patients, and we're now at about 125 patients. So how do you do it? So the way you do this is you upload your prior angiogram, and then you create a metallic silhouette of the coronary arteries, right? So we know where all the branches are, we have the roadmap, and then once we've done that, then we measure the flow. So here you can see that this patient has an ischemic lesion in the left anterior descending with a low FFR and a low coronary flow reserve. So this patient has the most to benefit from PCI. Has ischemia, also has a coronary flow reserve in a large dominant territory. So then what you do is use the ultrasound and you map exactly where you want the stent to land. So if you look up here, proximally in the vessel, we see a nice area where we can land without disease. That's 4.5 by 4.4 millimeters. And distally, we find another branch point or another point where the artery is free of disease. And then we simply measure the distance between these two dots, and the ultrasound does this for us. And as a result, we know we need to put in a 40 by 38 stent. There goes the stent, and then we re-image by IVUS and show that the stent is now expanded, and then we measure the flow. And so now the flow has gone from abnormal to normal. The coronary flow reserve has gone from very low to almost super physiological. This is probably because this patient had a fistula already made but was not on dialysis. But you can see that we've relieved ischemia and left the patient without a complication in a fully expanded stent, without any use of contrast. So what are the imaging and physiology outcomes? Well, first of all, you'll see that the pre-FFRs are quite low. These patients have the need for revascularization. The coronary flow reserves to begin are very low. And finally, that once you perform revascularization, that there's a significant improvement in their flow reserves. Who gets an angiogram? So obviously we can run into trouble here, right? Who should we take a picture in? So what we have is predefined any patient who has post-procedure symptoms, any patient who has EKG changes that are not resolving, where patient's coronary flow reserve does not improve, if they have an ischemic FFR that continues, or if the patient has a new effusion, they all get an angiogram. Other than that, we don't inject dye at the beginning, at the end. It's all done using physiology and ultrasound guidance. And then finally, in our first study, no patient received contrast, and what you can see is that the follow-up GFR at 30 days really didn't change at all, and there was no events. We did a 6-month propensity matched analysis. This is really hard, guys. It's very hard to find a control group for these people. I've searched high and wide for any data about what happens to people with CKD 5 or 4, with GFRs less than 30. I can't get it. And at CRF, we're pretty resourceful. We have a pretty long reach to find the data. I can't get it. We're still searching, putting things piecemeal, because now we're trying to publish our 1 and 2 year data for these patients. And I think it really provides more meaning if there's a control group, or at least a propensity match group. But at 6 months, you can see there's a significant benefit in the patients who undergo contrast nephropathy, who undergo zero contrast. So we've expanded this dramatically. We were a little cautious at the beginning. Now we do everything. This is a zero contrast rotoblator case. This is a zero contrast retrograde chronic total occlusion. So this is a patient who has a completely blocked artery. So the wire is not going to go antegrade. This is retrograde through a vein graft, a reverse cart, which we have done about 18. So really can take these very, very high-risk patients and complex lesions. This is saphenous vein graft, again using imaging to guide the procedure. This is near-infrared spectroscopy, which shows that this lesion is highly lipidic and not fibrous. As a result, we place a filter, I think you can see it here, and perform a zero contrast PCI without any complications. This is complex high risk. This is a patient with a distal left main, an EF of 10%, and you can see that we're performing a zero contrast Impella assisted left main bifurcation stenting. So there's really nothing that we don't do anymore using zero contrast. So I thought in the next few minutes what I'll do is talk to the interventionalist about how we do this kind of step by step, and then talk a little bit about where we are now. So here's a 68-year-old guy with normal ejection fraction, CKD stage 5, who presents with progressive angina and shortness of breath. He's on good medical therapies, intolerant to nitrates, and his primary cardiologist has referred him for coronary angiography to our center. So we guide hydration in patients with CKD 4 and 5 a little bit counterintuitively in the lab, not before the lab. So why do we do that? So when we measured this, we found that many of the patients who in CKD 4 and 5, if you prehydrate them, by the time you get them into their lab, now their end diastolic pressure is 25. Because they're overhydrated, they don't make urine or make urine easily, and as a result, now they're drowning. And so now you've got yourself into a situation where you're putting the patient at more risk. So what we do is we bring the patient into the lab. The first thing we do in every case is measure the end diastolic pressure, and then we guide the hydration in the lab by measuring EDP both before and after the case. There can be no better hydration because you're actually monitoring it almost in real time. And this is kind of cool. So how do you know you're in? How do you know the catheter's engaged? So we figured out that if you deliver normal saline down the coronary artery, it will conduct. And if you can see in this example, the baseline EKG, when you deliver intracoronary sodium chloride, you can see there's significant ST deviations. So that way, you don't have to use any puffs of contrast. So just by delivering saline into the coronary, our fellows have all learned that they're ready and can take a picture without wasting any dye. And so this is how you do it. So there's no use of a groin shot, so to speak. This is all done using ultrasound. There's one picture on the right side, and then two pictures on the left side. And so where are we with this? So we have the following questions. The total contrast used is 9 mils, but there's a lesion in the middle of the LED. There's potentially a lesion in this proximal obtuse marginal, and there's something in the mid-right coronary. So we have ambiguity. So when we have ambiguity, we can measure it, right? So this is instantaneous wave-free ratio. This is a surrogate measure of flow by pressure, and we can see that the RCA is completely normal. We measure the circumflex, and it's completely normal, so they don't require revascularization. But in the LAD, we have a positive result, so this patient needs PCI. And then we also have these techniques such as a pullback. And this pullback, what it allows you to do, it shows you the step-ups along the length of the coronary artery exactly where the major pressure drops are. And so by doing that, we can map where's the most bang for your buck. Where do you want to place your stent to improve the flow the most? And so then you use ultrasound. And so here's an example of where we're mapping the coronary artery distally at a normal segment, and it measures at 2.8 millimeters, and then we use ultrasound to tell us what the plaque is made of, and that will tell us how we prepare the lesion. Do we need to do high pressure dilation, cutting balloon, atherectomy? Instead, we know that this is actually a very simple lesion, and the distance from the normal vessel distally to proximally is 30 millimeters, and therefore we can put in a 2.5 by 30 millimeter stent. And then what we do is we use ultrasound or optimize again, and when we re-ultrasound, we see that there's one area that's 9.1 millimeters from the proximal stent edge that's just a little underdone. So we know exactly where we're going to do our post-dilation, and this is that targeted post-dilation. And finally, at the end, we not only can measure the flow in the main vessel, but because we've stented across a major branch, we can measure whether or not we've caused any damage. And by sliding this pressure wire into the side branch, we can see that the flow is actually normal, as it is in the LAD. So this is a completed revascularization, measuring flow and measuring the artery from the inside to make sure there aren't complications. And so if the patient has symptoms or EKG changes or new effusions, you perform an angiogram. If not, you recheck the EDP and the case is over. So one more case which I think is illustrative. So this is a 57-year-old woman with HIV, a reduced ejection fraction, multiple stents in the past, CKD stage 5, and this is the type of patient that we now get. So she gets admitted to an outside hospital because of shortness of breath, and she has a non-ST elevation. She gets diuresis, no left heart cath. She gets discharged the next day. She goes back because she's still having chest pain and shortness of breath. Then they do a nuclear stress test, and the nuclear stress test is positive, but she still doesn't get a cath. She gets an up-titration of her anti-anginals. So she's been to the hospital now 3 times with the same symptoms, and they've done the same thing. So finally, she comes across the bridge and comes to Columbia, and we do a minimal contrast angio for her. So this is her right coronary artery. It's 2.4 mils. And we see right away that there's collaterals to the LAD, which means it makes sense for us to potentially use a guiding catheter. And then on the left side, you can see that there's very severe left anterior descending disease and proximal and distal left main disease. So now we need an interventional plan. So we've given the dye that we know. Her EF is very low, so we take a break. You give the patient a little rest. And now we have a roadmap. And the plan for this patient is we need to determine whether we can do hemodynamic support. You saw her numbers were very bad, so we decided to do this with Impella assistance. So we need to be able to fit the Impella in. So how do we know if we don't take a picture of the iliacs whether we can fit it in or not? Well, we have tools for that too. And then my plan was to create a wire-based metallic silhouette and then stent the LAD and then stent back into the left anterior descending using ultrasound and then finally by physiological assessment. So this is real-time ultrasound of the iliac. So we're using a conventional IVUS catheter in high definition, and you can see as we pull back that the range of this is 5 millimeters and the artery is much larger. So as a result, I know I can easily place the impella. And so this is then a good example of how we can use the dynamic roadmap. So we didn't have this before, but you can see you can actually guide your wiring using the dynamic roadmap, which will actually move with you as you move the camera without any dye at all. And so here's an example of using that to wire the left anterior descending. And then you can even wire the smaller side branches without risk of perforation or risk of damage, all by using either a previous roadmap or by using this dynamic roadmap, which is very useful. And so what that allows you to do is perform a very targeted PCI. And so we know exactly where we need to use our balloons, and we could use the ultrasound to map where we need to be. And so we do the same thing that I showed you earlier, and that is use the ultrasound to determine what is the plaque morphology. What's it made of? Is it calcified? Is it lipidic? Is it fibrous? And what is the distance between normal to normal? And then we create it like a procedural map. So we know the lesion length here is 45 millimeters. We know we're going to stent right into the left main. We want 3 millimeters into the aorta, so we need 51 millimeters. And so what we do is we find two landing zones. Our first stent is going to be 28 millimeters. Second stent is going to be 23 millimeters. And I'll show you the precision that you can get if you rely and trust these technologies. So I know distally I need a 2.5 by 28. Proximally I need a 3.5 by 23. And then again, you can even wire these small side branches to protect these because you're not going to take a picture. So we want to be as protective as possible, especially in a patient with low EF. And then we can use these maps to actually start placing our stents. And the IVUS will tell us exactly where we need to perform any post-dilation. And so here you can see that by performing a targeted post-dilation, the ultrasound shows us that we've significantly increased the area of the stent. And then finally, this is how we map the left main. So what we don't want to do is leave 10 millimeters of stent in the ostial left main. We also don't want to miss the left main. And this is the camera in real time, which shows that we're right at the tip of the aorta. We press on the pedal and show that this is exactly where the proximal edge of the stent needs to land. And we can land the stent with great precision and accuracy and then perform a targeted post-dilation. And you can see on this picture here that we've basically just landed outside of the aorta right here. So 3.1 millimeters into the left main. And then finally, we want to make sure that we did a good job. Again, we're not using any dye, so we perform an FFR in the side branch to make sure that we haven't created ischemia in the circumflex, which we have not. And then we can measure the flow. And so we measure the flow using this device called a Corventis, and that tells us that the flow is completely normalized in the left anterior descending. And that's the end of the procedure. Of course, the proof is in the pudding. So you can see that this patient, even when she had ultra low contrast angiography with 9 milliliters of dye, she developed a contrast nephropathy. So you can imagine what would have happened if we gave her 50 milliliters of dye. She'd be on dialysis. So these are extreme risk patients, low EF, anemic, all the risk factors. But look after the PCI. So we perform the PCI and basically nothing happens because we don't need to use any dye. So this lady's now a year out. She has a really interesting story. Her daughter lives in France, and she'll do anything to not go on dialysis, because if she goes on dialysis, she can't visit her daughter anymore because she won't be able to get dialysis in France. So it's a major life-changing issue for her. So where are we next? So what do we do next? This is the latest and greatest, I'd say. So now we've started using optical coherence tomography, which has even a higher resolution than IVUS, which I think is benefit when you're not going to use dye. And one of the problems, of course, with OCT has been this use of contrast. So we are developing new non-nephrotoxic methodologies. And I think this is kind of cool because one of these is contrast and one of these is solution X, which is completely injury-free to the kidney. So we are working, and hopefully very soon we'll be able to give you the solution, what this is, so that you'll be able to perform OCT with great resolution without the use of contrast medium. This is very cool, I think. So this is mapping of the coronary artery using CT, which you guys do a lot of, instead of using angiography at all. So this patient had a CT, has never had a diagnostic angiogram. Not only does she have a creatinine of 5, but she has anaphylactic reaction to contrast. She has severe coronary disease with life-limiting angina. And so we use the CT, and we use this technology from Siemens called the DynaCT, which you guys have. And the DynaCT can happen inside the room. And then you can actually map the patient's outpatient CT onto their DynaCT and basically create a silhouette that's sitting on the X-ray in front of you. And then you basically can see, this is an example where you can wire the coronary artery based on the CT guided map, and as a result perform your PCI. So here's an example where we did this, and we basically measure the flow in all 3 arteries without an angiogram. The right coronary is normal. The LAD has diffuse disease, but the circumflex has a very severe and significant step up. And so we know that the likelihood is that the limiting lesion is in the circumflex with a very low IFR. So we treated that directly with PCI using the technique that I described to you earlier. And then you can see that we've completely rectified that problem with no further gradient. So I'll finish there, and I'll conclude that in patients with advanced CKD who require revascularization, that we can perform PCI with very low risk and very high procedural success. Thank you very much.
Ziad, that was, as expected, absolutely marvelous. So, I mean, you got a question?
Yeah, I had a question. I don't know if I
Go
missed
ahead.
this, but we used to hear a lot about carbon dioxide being injected for contrast. So what happened to that?
So you can't do carbon dioxide in the coronary because you can't perfuse. So you'll be profoundly ischemic if you inject carbon dioxide into the coronary artery. You can do it in the periphery. It's not a problem because by the time it goes through the pulmonary circulation, it's all basically dissolved. But in the coronary, you'll create profound ischemia, so it's not possible.
Thank you.
So, Ziad, this looks, you know, this is mouth-watering stuff. PCI, no contrast, almost no worry about CIN. But tell us what your screen failure rate is. How many patients are sent to you for contrast-free PCI who you can't do? How many patients do you start with contrast, with the intent of doing contrast-free PCI and end up having to use contrast?
That's a great question. I should include that. So we accept everyone. We turn down no one. And I would say that the screen failure rate would only happen in patients with chronic total occlusions where we cannot see collaterals, arteries. Otherwise, we'll do 100% of patients. So I would say overall our screen failure rate is less than 5%. And our use of contrasting these patients is probably about 3%. So in 3% of patients, there's some residual problem and that is not picked up by either the IVUS or the FFR or IFR, which basically includes persistent EKG changes or persistent symptoms. And then we take one angiogram with 5 milliliters. Otherwise, none of these people get any contrast.
I really enjoyed your presentation, and I think it's time, definitely, to, with all the imaging technologies and all the physiological things that you have in the cath lab, to think about that in these patients. Two questions for you. Where do you see future developments of fusion technology, imaging technology, to help you guide and everything else? And you showed us some of these pictures. So where do you see, even going further? And two is, and this is the most difficult population to use imaging alone without dye, because with chronic kidney disease, obviously quite a few of them are diabetic with diffuse disease and so many other things. What's, in your experience, the complication rate of such procedures? Because, I mean, they really have bad disease compared to many others.
So I'll answer the first question, which is where do I think imaging is going in this population? So I'm proud to say that our specialty is really the only specialty in medicine that does its own imaging. And that's an amazing opportunity for us because we have control of it. So I think everywhere from structural heart disease to coronary disease to endovascular disease, we have the opportunity to push this field forward where the radiologist cannot because we don't have a gatekeeper. So this hybrid technology, which Neal was talking to me about yesterday, you have someone from Siemens who helps. The marriage of industry and physicians in this area is just unsurmounted. So structural heart disease, fusion of CT imaging, fusion of MRI, in the coronary space, in the structural space, I think it's going to be the future. And I think it's going to be widespread. The key is that we don't leave people behind. So there needs to be an investment into intravascular imaging and structural imaging that becomes a part of the core training, not so that you have 5 people who are world-class at it and you have to go and have your procedure. From a population perspective, this has to be done for everyone. The second question, which was the complications part, is quite near and dear to my heart because I think everybody should have PCI like this, even if you use dye, right? So if you use a pressure wire to prove there's ischemia, if you use a pressure pullback to show where the ischemia is and where the most bang for your buck is, and everybody gets an ultrasound before or an OCT before, and you make sure that you don't leave a complication behind, that's how we improve the outcomes in these diffusely diseased, complex, and high-risk patients, and we don't do that. We often take the most high-risk patients and try to get in and out as quickly as possible, right? Just slam a stent in, move on to the next patient. Or we put the Impella in, we do every vessel PCI, but we don't image or use any physiology. So the outcomes in this patient population, I think we can match to the conventional population because we're pulling out all the tricks and making sure that we did our job, which is to relieve ischemia and leave no complication behind.
Yeah, that was a tremendous presentation. And a couple of questions. As at the end, you kind of moved into the Dyna CT fusion world. It's a little clunky in order to be able to do that at the moment. One of the rooms that's being built here has a real CAT scanner in the room. And the advantage of that is you can almost get automatic fusion with those patients. Now, we use it all the time in the peripheral vascular world. It's part of our workflow. If we're going to put an endograft before we even scrub in the room, non-contrast cone beam is done, images are fused, all the target space here marked, then we scrub in and do the case. We don't have the same amount of motion as you've got basically in the heart. And the question is, using fused images, 2 questions really are. Number 1, how do you optimize? Because one of the things that we've not quite got here is a diagnostic CT scan is not just a diagnostic CT scan, it is a roadmap for treating that patient. That must be optimized for you to help you be, and therein lies a gap that we kind of need to close a little bit. It's what I really need to know how, I'll give you an example of my world, endoleak targeting. That's a whole different timing issue from when the dye arrives, basically, to be able to get it. And there's ways of optimizing the preoperative imaging to make the intraoperative guidance a little bit easier and a little bit more accurate. So number 1, have you approached that? Number 2 is the motion correction is really basically where I'm going with the dynamic roadmap, and you showed it's impressive, but that's not fused images.
So, so the first question is about how can we optimize this? So I think we can learn from some of the new technologies in this area, for example, HeartFlow. So HeartFlow, as you know, is a technology which measures CT-based FFR. And what we've learned from them is that using even a 64 slice scanner, you can get incredibly high quality images, and that the key is to slow the heart rate down. Now, you guys are in a tremendously unique situation because you have a cath lab that's attached to a CT scanner so the patient can be adequately beta blocked. And I could envision the patient coming in who has symptoms, having their CT scan. We quickly peruse the anatomy to see whether there's any lesions or not. If there is a lesion, it'll give you the CT FFR, and you will be able to determine whether there's a physiologically significant lesion. You know exactly where to put the wire in which artery. You slide that patient over to the other side, put the pressure wire down, measure it, use the ultrasound, put your stent in, the patient's on their way. That's the vision, right? You've got anatomy. Those patients who have no disease, they're on their bike and going back home. The second part, which was about optimization, right?
Preoperative imaging, you've talked about that, and the motion artifact.
Oh, so, you know, we're really pretty good now. So diastolic gating for coronary arteries is as long as we can get the heart rate down and have a prolonged end diastolic time, you know, it's pretty good. We want to aim to get to the heart rate around 60. You guys actually have a much bigger CT program than we do, but that's where I think the key arrives.
So if I can ask one other follow-up, we've been very interested in catheter robotics for AFib, the periphery, and the coronaries. As you know, about probably 2 weeks ago at TCT, the first remote coronary intervention in a pig was performed using robotics. One of the first autonomous movements of a robotic catheter occurred here in a model, not in a patient. Locking in the preoperative CT, fusing it, drawing that center line, which is a glide path for a robot, and having that thing tracking automatically. And so I'm really interested. So I see robotics and imaging as being one and the same thing and combining those two. And I'm interested in your vision of where this is going to go in the future.
Yeah, so we have a CoroPath system, which is basically allows to perform robotic PCI, and I think that the major advantage of that robotics fused with imaging is precision. You know, when you're talking about arteries that are millimeters in diameter, and we have very little gap between normal and diseased tissue, there's no question that the robot's going to beat the human in that situation. I think where we need significant advance in that is the complexity of lesions that we now deal with often require multiple guide wires, manipulation of catheters, and that's where the robots need to really, I think, improve. But the fusion of robotic technology with imaging is really, I think, the future.
Thanks so much, Dr. Ali. Very interesting talk and cutting-edge stuff. I'm not a nephrologist, but for the record, I hate contrast-induced nephropathy with a passion. A lot of our patients being evaluated for TAVR are sitting ducks for CIN. They have all of the risk factors that you've described. And we know that if they get AKI post or pre-procedure, that their outcomes are worse. A lot of them undergo coronary angiograms and CT TAVR protocols. Where do you see the role of these technologies, like if they require PCI pre-procedure without contrast? Do you see a role for this? Is there data on it?
Yeah,
what's your experience?
Great question. So first of all, we are now doing our pre-TAVR evaluations with 50 milliliters. And those patients who have very severe CKD, we use transesophageal echocardiogram and ultrasound in the iliacs. So we'll do it completely without. We have been doing, for those patients, usually about 10 milliliters right before valve implantation. Probably in the last 3 or 6 months, we've eliminated that and have now performed zero contrast TAVR as well. The patients who have advanced CKD and who are going for TAVR and require PCI, they're usually referred to me, and we do them without dye. So the other additive fact that we didn't talk about in great detail that puts the TAVR patients at particularly high risk is not contrast, it's the hemodynamic induced instability that can lead to kidney injury. But of course, they're all additive. So if you can eliminate the contrast and you have some insult, you can probably, get as many nephrons back as possible. So that's what we do now. Very limited contrast for even our most regular patient. We have a large series of work that we're working on with the nephrologist, which shows that even small amounts of contrast can kill nephrons, and you never recover them. And so while that doesn't impact you when you have a GFR of 60, when you've had your 4th or 5th cath, now kidney decline is starting to go up. And there's actually a good Veterans Affairs study which shows that very, very nicely in endovascular disease, that there's this clear trend. The more caths you're having, of course, the hard part is to eliminate the fact that they're also the most diseased patients, but there is a clear trend towards the fact that they develop worsening kidney failure much more rapidly than those who do not.
Thank you, Ali, for a great lecture. I want to ask a couple of questions from fellows' perspective. Since you're a training center, so in your experience, what is a training curve like for the fellows for a zero-contrast PCI? For example, you've shown us finding saphenous vein grafts with guide wires and the catheters. Would you let your general fellows do it?
Yeah. My general fellows, they do this every day. I don't even go in the room. So when we're performing the diagnostic angiograms, the fellows know that when they get the feel of the catheter, which I think is an incredibly useful thing, so when they get the feel that the catheter's in, they inject saline down the coronary. And if they inject saline, see that they're in the coronary, I say, okay, you can inject. So I think that it's improved their tactile feel rather than just their visual stimulation for diagnostic angiography. And then all of our interventional fellows gets pretty heavy-duty training in intravascular imaging and physiology. So this is just a part of our program now.
Thank you.
Okay, further questions? Well, Ziad, thank you very much for that lecture. It's been amazingly enlightening.